Perfect. It is being recorded. So I will do a brief introduction of Dr. MacLean. He will do a presentation. This will be followed with Mohammed, which will be discussing the review paper, followed by myself, and followed by Pedro. And again, during and throughout the session, please feel free to ask questions. That'd be wonderful. Okay, so now to the start of the meeting. So Dr. Mark MacLean is a PGY-3 and Neurosurgical Resident at Dalhousie University. He's born and raised in Halifax. He completed his First-Class Honours B.Sc in Chemistry in 2011, followed by an M.Sc in Medicinal and Pharmaceutical Chemistry in 2013, and his M.D. in 2018, also all at Dalhousie. He is an emerging leader in the neurosurgical community. He's currently serving as a Vice President of the Canadian Neurosurgery Research Collaborative, which is a collaboration of various residents across the country. He has published numerous peer-reviewed papers and has been a recipient of several awards. The most recent one that comes to mind is the prestigious McKenzie Memorial Prize, which is considered to be the top research prize in Canada for any neurosurgery resident. So we're very, very happy that he could join us today, and we're excited to have him lead our second Journal Club meeting, the topic of which is chronic subdural hematomas, a paradigm shift in pathophysiology and treatment strategies. Mark, the floor is yours.
Thanks very much for the kind introduction. Absolute pleasure to be here this evening. I'm really looking forward to it. I think we've got a pretty nice schedule of different topics we're going to discuss tonight. I am a strong advocate of CAMSIGN. I think it's a great initiative. It's always good to explore interests and early on in medical school, and I think this is a really great opportunity and venue to be able to create some discussion. So as mentioned by Simon, we're going to start off with a little bit of a presentation from myself, and then we're going to have a discussion of some of the papers which I think nicely capture this evolving topic. And then hopefully we leave some time for questions regarding anything and that you guys wish to discuss, trials and tribulations of medical school, residency, you name it. So I think without further ado, I'm just going to share my screen here and we can get started. All right. So as it is, can you guys see my pointer currently? My mouse?
No, we can't.
No, we can't, unfortunately.
Okay, just one second. All right. Okay, so we'll get started. I have annotations on most of the slides anyway to draw attention, so I don't think it's going to be a big deal that we can't see my pointer. But so the topic of today's discussion is chronic subdural hematomas, and this is one of the most common neurosurgical pathologies, and I think today this topic is quite nice because there's been long-standing, pervasive thought process as to how these should be treated, and as basic science and fundamental understanding of these lesions has changed, so has the potential treatment options. And so I think we'll be able to nicely cover that today. So again, thanks for having me. In terms of the objectives for my rather short or abbreviated talk, I'd like to first just give a little bit of background about Halifax. I'd be remiss if I didn't mention my hometown and the reasons for my choice of staying at Dalhousie for neurosurgery residency. And then we'll talk about this paradigm shift, so to speak, in terms of chronic subdural hematoma management, and a little bit of anatomy just to set the stage before we discuss the articles. So just a couple of photos. So, Halifax out on the East Coast, I'm sure, some of you have probably been to Halifax at one point or another. But this photo, I think, just nicely captures the fact that we're on the coast. We have harbor, we have a lot of waterfront, And you can see there in the center, Stittle Hill, which is a historic property on which the city was founded. And beautiful in the summer times. There's a lot of restaurants in the city. There's lots to do. And even though it's, a smaller city in terms of the overall population, it's got a proper city feel to it. This is just a shot of our waterfront. So our neurosurgery residency program actually had lunch at this restaurant recently with our program director as part of a resident retreat. Just a short walk from the hospital, and it's just absolutely beautiful. If you're considering neurosurgery residency and you're thinking about Dalhousie, another great reason to consider it is we're actually close to the Annapolis Valley. This is an absolutely gorgeous spot. There's a lot of wineries for those that are interested in that sort of thing, or lots of hiking as well for the outdoorsy types. This is just a nice shot of the Annapolis Valley, and our residency group actually had a hike in the Annapolis Valley fairly recently with our staff as a team bonding experience. And outside of the city, probably only about an hour and a half to 2 hours drive away, we have Kejimkujik National Park. So again, there's lots of opportunities, especially for those in BC who are used to being outdoors and enjoying that sort of thing with the mountains. We do still have a lot of natural beauty out here. And so, if that's your type of thing, it's just another good reason to consider Dal. And so Dalhousie itself is the biggest university in the Maritimes, and is the biggest in Halifax as well, though there are a couple of other universities here. And this is just one of the main buildings on campus on a nice summer sunny day. And we have a number of different locations where, sort of cutting edge neuroscience research is being conducted. So we have our Life Science Research Institute there in the top left, and on the right, where there's a lot of basic science being conducted, and it's home to our Brain Repair Center. And then in the bottom left, it's one of the medical student buildings, the Collaborative Health and Education building, which is brand new, where we, have training with simulated patients and things like that. Overall, it's, there's a lot of development at Dalhousie, and some great research being done. In terms of our neurosurgical faculty, we have 10 neurosurgeons. I'm going to show them on 2 separate slides here. And these neurosurgeons cover almost all neurosurgical pathologies that you would encounter. So we are a tertiary center in Halifax, and so we cover epilepsy surgery, we cover pituitary surgery, and we do endoscopic endonasal procedures. We have coverage for complex spine, minimally invasive spine. We have neurosurgeons who do both open cerebrovascular and endovascular neurosurgery. We have a children's hospital just down the street where we actually do on-call coverage, and broad spectrum of pediatric neurosurgery as well, spinal dysraphism, hydrocephalus, and neuroendoscopy. These are our other neurosurgeons here. Dr. Stephen Maloney is a prominent cerebrovascular neurosurgeon, well known to the neuroscience community, who recently joined our program as well. And I'd be remiss if I didn't mention our neurosurgery residents, because really it's your colleagues that make a program special. And neurosurgery residency is 6 years in Canada, and it's a long haul, but certainly your colleagues make it all worthwhile. And so here you can see at Dalhousie, from upon the top row there, from left to right, Omar, Alwala, Erica, Mosab, and Jay. And then on the bottom row, myself, Jenna, Catherine, and Aziz. So, we have a tight-knit group, and colleagues make a program worthwhile. So when the time comes and you are applying, it's important to consider the people you're going to work with. They become your family. And the last thing about Dalhousie that I wanted to mention was just in terms of the neurosurgical procedures that we do. We cover cerebrovascular, pediatric, functional, and spine. You can see there's about 40% of the practice is spine, and then the rest make up are broken down. You can see there 23% cranial. That would be mostly neuro-oncology, open cerebrovascular. We have endovascular as well. We're seeing about 7,000 patients in clinic per year, and then we're also carrying out about 1,400 neurosurgical procedures per year as well on average. And then of course that's changed a bit with COVID recently. But it's just to say that at Dalhousie, we pride ourselves on having a very strong clinical neurosurgery focus. And so there's lots of research opportunity, but one thing's for sure is that when you graduate from our program, you have a sound training and a broad exposure to all the different pathologies, and there's no shortage of cases. So with that said, a little bit of an introduction to Halifax. We'll move on to the good stuff. So a little historical tidbit. We're all familiar with Virchow. Yes, the famous Virchow. Many years ago, Virchow, when encountering a subdural hematoma, had termed it pachymeningitis hemorrhagic interna. Must give the guy credit, because the thinking here was that there was an inflammatory process going on, as implied by the itis here. And this was a long time ago, but that thinking actually fell to the wayside. And although this was probably actually spot on, theories evolved as to how subdurals occurred. And given that there's a significant association with traumatic brain injury and motor vehicle collisions and other sorts of head injury, the thinking sort of shifted to more that there might be damage to bridging veins that are from the cortex to the dura and things like that. And so I think it's important that we kind of just touch a little bit about or a little bit on the evolution of why that is. So I'm not going to spend a whole lot of time talking about acute subdural hematoma, but I think it is relevant. So with acute subdural hematomas, these are quite lethal, and one of the reasons for that is they are significant. There is a significant association with cranial trauma. So oftentimes when patients are in a motor vehicle collision or a significant head injury, there is injury to the underlying brain. So not only does an acute subdural form in some cases, but there's injury to the underlying brain. So that can be contusion, or it can be a laceration to the surface, to the cortex. And the subdural adds to this by its mass effect, causing midline shift, distortion of intracranial structures, and can be associated with significant cerebral edema. All in all, these contribute to the lethality of acute subdural hematoma. So it's no surprise that there is a thinking that there's a connection here between having a cranial trauma, developing a brain bleed, and that leading to poor outcome. So again, one of the main thinking in terms of the etiology of why these acute subdural hematomas form is that there are these fragile bridging vessels, and especially in elderly patients where there's significant cerebral atrophy and there's space or enlarged compartment, a subdural compartment, those fragile vessels, those fragile veins can get torn. So if a patient has a significant acceleration or deceleration, with a cranial trauma, that could lead to tearing of these vessels, and then you leak blood into that compartment, and hence you get your subdural. And then there is also underlying primary brain injury, as I previously mentioned. So that can involve injury to the parenchyma, such as with laceration off of the inner table of the skull, damage or disruption to those fragile peel vessels, damage to the arachnoid granulations, or to penetrating branches, superficial penetrating branches in the cortex, vessels that is. And not helping matters would be the fact that a lot of patients are receiving anticoagulation therapy. And it's highly prevalent. Many patients are on warfarin, they're on novel DOACs, they're on antiplatelets such as Plavix or aspirin. And generally speaking, it does increase the risk of acute subdural hematoma, 7 times in males and about 26 times in females. So there is a significant correlation there. But you might ask yourself, well, what's the relevance here? Why am I talking about this? It's because there are a large number of patients that actually have an acute subdural hematoma or chronic subdural hematoma that have no head trauma. So there's got to be more to the physiology here. So let's transition. Let's talk about chronic subdural hematomas, because it's the reason that we're here. So in terms of the presentation, these patients often present with focal neurological deficits. They can have decreased level of consciousness. They can have confusion. They can have hemiparesis, so unilateral weakness. They could have bilateral weakness. They could have sensory dysfunction. They could have headache. They could have seizures, or they could have language arrests. They could have dysarthria. They could have aphasia. When we're following these patients, oftentimes we do obtain CT imaging. CT imaging uses X-rays. It's good for looking at bone. It's good for looking at blood. And it would be the mainstay of how you're going to follow a patient with a brain bleed. So on the top, you can see a hypodense collection overlying the cortex. And a chronic subdural is, by definition, hypodense. On the bottom row, you can see that yellow arrow points to a mixed density. In that case, it implies that there's some acute blood as well. So not every subdural hematoma that's chronic will be totally hypodense. There can be irregularities, there can be mixed density, there can be some hyperdensity, and certainly that's the case if membranes form, which is going to be a topic for tonight. So how and why do chronic subdural hematomas form? This is really the crux of what we're going to try and get at tonight, because it has implications for how we treat these. So it's important to ask, what percentage of head trauma or what percentage of chronic subdural hematomas have an inciting head trauma? You might be surprised to know that the answer is less than 50%. So a significant portion of these patients do not have an inciting head trauma. So again, there must be more to the physiology here. So one of the things we can do to help us give us some information about the physiology is to look at general risk factors. So with age, we know that the brain atrophies. There's more of a space in the subdural compartment where you can have blood collect. There's also more potential for the head, for the brain to actually, generate a significant impact by bouncing off of the inner table of the skull. Alcohol use can lead to falls and trauma. It can also exacerbate cerebral atrophy. Patients can have seizures. Cerebral spinal fluid shunts change the pressure dynamics within the brain, and as such can also lead to hematomas forming as well. And then of course, coagulopathies. So your use of your aspirin, your Plavix, your warfarin and such. So those are risk factors for just generally getting or developing a chronic subdural hematoma. But what about risk factors for spontaneously developing a hematoma? So these would be risk factors for patients that do not have any history of head trauma, as far as they know. Hypertension, so high blood pressure, vascular anomalies. So this could be arteriovenous malformations, dural AV fistulas, or other vascular anomalies. Tumors, infection, again, substance abuse, vitamin deficiencies, coagulopathies, so patients that have problems with their blood clotting, or intracranial hypotension. So kind of similar to cerebrospinal fluid shunts, there's change within the pressure in the brain, and those pressure dynamics can lead to blood collecting on the surface of the brain. So where traditionally it was thought that there was torn bridging vessels over the surface of the brain, if you go to the Greenberg, one of the neurosurgical handbooks, it is updated, and the most recent version does have a relatively up-to-date pathophysiology, which is good. So the yellow arrows just highlight a couple keywords, but I'll just read it. So many chronic subdural hematomas probably start out as acute subdurals. We know now that there are a significant portion that do not have head trauma, that do not, we don't image them and see an acute subdural. They show up and they have a chronic subdural. Whether or not they have a head trauma, that's another story. Blood within the subdural space evokes an inflammatory response. So again, key to the pathophysiology here that we're going to get at is inflammation. Within days, fibroblasts invade the clot, form neomembranes. So again, key to the development of these will be this membrane. And this is followed by ingrowth of neocapillaries, fibrinolysis, liquefaction of blood clot, and breaking down the byproducts. So there's a lot going on here. This is pretty wordy, but what we're really trying to get at is that the pathophysiology of how these form can be generally broken down into the triad of inflammation, so an aberrant inflammatory loop, angiogenesis, formation of small leaky blood vessels or capillaries, and fibrinolysis, not forming good blood clots and thus having the propensity to develop persistent chronic subdural hematomas. So if you want to treat a chronic subdural hematoma, it would be ideal if you could do so with medical therapy. And we know that if inflammation and leaky blood vessels are key to the pathophysiology, then steroids would sound ideal, would they not? Well, what's the relevance here? There are many neurosurgeons around the world who use Decadron or dexamethasone, corticosteroid, for patients with chronic subdural hematomas. So we should look a little bit into this. Now, one of the things that we can do is we can look and see what literature is out there for use of steroids in brain injury in general. And one large trial called the CRASH trial examined or looked at the use of steroids, corticosteroids specifically, in patients with traumatic brain injury. So again, these are not patients with subdural hematoma, but there is something that we can learn from this. This is it was a large trial, 10,000 patients with decreased level of consciousness who had basically within 8 hours of their traumatic brain injury, they received either 48 hours of steroid, so methylprednisolone, or placebo. And the main finding from this study is that steroids increase the relative risk of death by 1.5 times. And the Brain Trauma Foundation guidelines, so this is what we would go to, and this is published in the prestigious journal Neurosurgery, that guides us on how we manage these patients. The recommendation is that based on level 1 evidence that you do not use steroids for improving outcome or reducing intracranial pressure. So you might say, well, oh, you don't want to use steroids in traumatic brain injury. Should we use it in chronic subdural hematoma? And one of the things that's important to do is to think about what you're treating. There are a number of different types of cerebral edema. And we had mentioned that when you use steroids, if you decrease inflammation, you decrease leaky blood vessels, you could potentially have an impact on cerebral edema. Well, I've got cytotoxic highlighted there. And I'm going to talk a little bit about that because it's relevant to the study that I just showed you. There's a number of variables, though, that you need to consider when you're thinking about using steroids, you're thinking about the type of edema. So we're going to just go through this we're in very superficial detail. When steroids are used, so if you have a traumatic brain injury, the type of cerebral edema that you can develop is cytotoxic. So so first, if you look on the right, etiology. So there's a variety of different ways that you can develop cerebral edema. Tumor, infection, you could have traumatic brain injury, hydrocephalus, or large swings in your sodium or your osmolality in your blood. The BBB, that's the blood-brain barrier. In vasogenic cerebral edema, the blood-brain barrier is broken down. In cytotoxic cerebral edema, that's not the case. The mechanism for this would be aberrant sodium and potassium pumps. So if you're thinking about using steroids in traumatic brain injury, which alters the sodium potassium pumps and causes cytotoxic cerebral edema, it's just not going to work because steroids are more ideal for use for vasogenic edema. And that's something that's relevant because you can develop vasogenic edema from steroids. And one of the main reasons we use steroids in patients with tumors is exactly that, to help decrease the vasogenic edema. But it's not particularly effective for cytotoxic. So it's not really surprising that it didn't work so well in the CRASH trial. If you go on to pursue a neurosurgery residency, you're going to be using Decadron all the time. It's important to know a little bit about the drug. I'm not going to spend a whole lot of time on this. It's a glucocorticoid. So when you're thinking about steroids, you can break it down into whether they have anti-inflammatory effect, so glucocorticoid effect, or a mineralocorticoid effect, so having impact on your sodium, potassium in the blood. And Decadron is almost completely a glucocorticoid, and so it's going to be used for more its anti-inflammatory effect. So if you have a patient with a brain tumor and you don't want to be having a drastic impact on, the kidney's function in terms of like sodium, potassium, things like this, and you just want to decrease that cerebral vasogenic edema, then it's ideal because you can see here in this table, that's mostly what it's having an impact on. And it's got a relatively long duration of action, and that's good as well, because then you don't have to be giving it all the time. So the half-life is around 6 to 8 hours. It works on the glucocorticoid receptor, which is found in the cytosol of cells. And when the decadron binds the glucocorticoid receptor, translocates into the cell and into the nucleus, and it basically works by a mechanism of gene transcription. Short-term effects, it's going to help decrease cerebral edema and decreasing the leaky capillaries. In the long term, we're going to be talking about gene transcription and regulation of inflammatory cascades. Now, one of the keys to one of the papers that we're going to discuss tonight actually does highlight differences in the side effects or highlights that when you use Decadron, that there are some certain side effects that do show up. And it's not surprising. There's a long list of different things that Decadron can cause that are not ideal. So, weight gain, high blood sugar, it can increase the risk of infections. There's no point in going through all of these, but one of the papers that we discussed tonight does highlight this point exactly. So even though it would be ideal to use this for chronic subdural hematomas, it's important to remember that it comes with its own side effect profile. In terms of the treatment of chronic subdural hematomas, it's important that you consider not just the hematoma itself, but also other issues that arise from the hematoma. So if you have compression on the cortex, the brain doesn't like that. It can become hyperexcitable. You can develop seizures. And so many times the patients, many staff neurosurgeons will put patients on anti-seizure medication. And certainly that's the case if they have a seizure. In terms of coagulopathies, if you can, let's say that a patient has a heart valve, you probably aren't going to, jump right away to try and correct their coagulopathy if they've got a chronic subdural hematoma, and that can add to the complexity of your decision making. But in some patients who have coagulopathies where that's not the case, and you can correct that safely, then you probably want to do so. And in terms of the indications for surgery, for example, usually it's pretty straightforward. If there's a lesion that has a significant mass effect and it's causing focal neurological symptoms, or the patient's deteriorating, or on radiographic imaging that the chronic subdural hematoma is progressing, you might want to treat it. And we're going to talk a little bit about the options. We talked about medical therapy. Decadron, for example, is one option. There are some others. And surgery and evacuation of the hematoma is another option. We'll talk about that for a second. And then, of course, endovascular therapy, one of the things we're going to discuss in our papers tonight. One of the tricky things here is there's no consensus. There are no great guidelines as to how to treat these lesions. So, for example, at any given site, amongst the neurosurgeons you work with, you'll find that in some cases, patients might be treated with a twistral craniotomy at the bedside. They might be treated with burr holes in the operating room. Some staff might use one burr hole. Some staff might use two burr holes. So holes in the skull that allow you to basically access the dura, open it, and irrigate out that blood clot. Sometimes staff will place a drain. Some staff don't place a drain. Others will alter the head of bed after the hematoma has been evacuated. So, for example, if you place the patient with the head of the bed flat after the hematoma is removed, the thinking is that it might help the brain re-expand and start to approach the intertable again of the skull to eliminate that space where the fluid could recollect. And then there's no consensus even on whether or not to image these patients after. So sometimes after hematoma has been evacuated, a neurosurgeon might get a follow-up CT scan to look and see what the status of that is. And then some say, well, I don't want to see whether or not there's a recurrence there unless the patient's symptomatic. So again, there's lots of different variables here. So in terms of outcomes, generally speaking, if you get a CT scan after you evacuate a subdural hematoma, there's usually some residual. You don't normally need to treat the residual unless it's progressing in size, getting bigger, the patient's not recovering or is deteriorating. And generally speaking, the mortality rate from the procedure of doing a burr hole to drain a chronic subdural hematoma is low. Some of these patients are just frail and highly medically comorbid, and then that is a result of mortality. complications that can arise, generally speaking, from doing a burr hole to drain a chronic subdural hematoma, the complications are not too significant, but the main one that I think is worth mentioning is that there can be a recurrence. This is the whole reason that this endovascular therapy has really evolved. I mean, there are multiple reasons, but one of them is certainly that the thinking is that by eliminating the blood supply, you can decrease the recurrence rate. So the recurrence rate for chronic subdural hematomas in the literature is quoted between 2 and 37%. It's approximately between 10 and 20%, I would say, amongst most studies. And it's usually patients that are elderly, they're comorbid, and they're on blood thinners. Those are the big risk factors for recurrence. So other proponents of endovascular therapy would say that it's a non-invasive option. But is doing a groin puncture or giving a patient a general anesthetic really a non-invasive option compared to doing a burr hole where the patient just has some local anesthetic infiltrated into the scalp, maybe a bit of conscious sedation? It's a good question. So why endovascular? Again, we mentioned the invasiveness compared to surgery, cutting off the blood supply, and ultimately endovascular therapies developed as a result of doing basically patients who were coming back with a lot of recurrences, doing embolization for those patients. But more recently, these studies are showing that it might be an alternative to surgery or used as an adjunct. So when do you embolize? Well, similar to surgery, if the patient is clinically symptomatic, but if the patient is deteriorating, you're probably not going to do an embolization. It's not advisable if the patient has a lot of mass effect and they're declining in front of you that you do an embolization. Those patients need surgery. If a patient is failed watchful waiting and steroids and it's persistent, then that might be an ideal patient to do an embolization in. But again, if a patient has mass effect and a neurological deficit, oftentimes they need surgery. This is a snapshot of PubMed, and these are just freely available numbers. This pathology has been around a long time. Look at that increase over to 2021 on the left, where you can see how many articles are getting published on this topic. There's a lot of renewed interest here. So even just from 2018 to 2020, I mean, there are tons of papers that are getting published on this topic. And here was a paper published from Cornell, a series of 60 patients, where one of the outcomes that they're looking at with this endovascular therapy is, can you decrease the size of the chronic subdural? Can patients avoid surgery? And then what's the risk profile associated with this? Here you can see that in their case, they said 8% of patients who had endovascular therapy had a recurrence. Remember that with surgery, it's about 10 to 20% generally. And then 70% had a reduction in size of that lesion. So very generally, again, there are a number of papers that have been published just within the last couple of years. These are just a couple of snapshots. As with any new evolving field, there's lots of review articles that get published. This is just a snapshot of one systematic review that was published fairly recently, and says the hematoma recurrence rate is about 2%. They're quoting that 27% is the recurrence rate for surgery, which seems a bit high, but generally the complication profile they're saying is pretty similar at about 2 to 4%. And this is another systematic review that was published. I mean, there's seriously a lot of literature coming out. The recurrence rate that they're saying down here in the yellow box for patients treated with a middle meningeal artery embolization the recurrence rate's about 2%. So that's pretty low. So that seems like that's pretty ideal. I mean, that's pretty convincing stuff. So it's definitely getting a lot of attention. But you can see that the case numbers are pretty small. Case series, generally speaking, they're not large retrospective cohort studies, right? So I guess the only reason that I have the Embolizate highlighted there is just to show that, again, there's not really standardization across these studies. There's lots of different techniques, and again, there's no standardization as of yet. And then this study was published like just within the month from the Barrow Neurological Institute in the States, where relatively large, like 231 patients, and they're advocating for use of this technique. Okay, so that's a little bit of background about the paradigm shift of chronic subdurals. I don't want to spend a whole lot of time on anatomy. This is just going to be a sort of fly through. Hope maybe just another 5 minutes on this, and then we'll move on. For anybody who's interested in learning cerebrovascular anatomy or doing some reading around this, neuroangio.org is a great resource. Maxim Shapiro of New York Langhorne has compiled a brilliant collection of information that's available. It has these beautiful pictures of the arterial vasculature, and I'm just going to just very briefly walk through an example. So hopefully I have some annotations here marked so that because you can't see my pointer, but so if you look here at that bottom, the blue arrow in the bottom right there pointing to J. So this is where the external carotid artery comes into the skull base through the foramen spinosum. And you can see that those blue arrows that are up top, pointing to S, pointing to T, pointing to U, those are the main branches of the middle meningeal artery. So S, that blue arrow in the top right, that's your frontal branch. T, that blue arrow in the top middle, that's your parietal branch. And then U over to the left, that blue arrow, that's your petrosquamosal branch. So these are the main big branches that you want to look, you're taking into account when you're embolizing. I just have a couple of shots here, just of some smaller vessels that you need to be very careful of when you're doing these embolization procedures. So the blue arrow here points to I. This is a tiny petrous branch of the middle meningeal artery. And whoever had the embolization paper might have noticed that they did mention this, that this little branch can supply the facial nerve and the greater superficial petrosal nerve. So if you don't take your catheter distal to this point or beyond this point, you put glue into that can be very problematic, and the patient could end up with facial weakness or loss of taste in the mouth. And there's also a small cavernous branch there that you would need to try and avoid. And then there's also another branch here, L, which is your sphenoid branch, which is going to have a connection actually over to the orbit. And there's connections to the ophthalmic artery. So if you are not careful and you get some of this embolization material into here, you could potentially end up causing visual loss for a patient. And when someone does this kind of procedure, there are variants that you need to be very cautious of. So if you look at the pink vessel that's coming in the skull base and then continues along as that red line B, then to A, this is an example of when the middle meningeal artery actually supplies the blood supply to the orbit. And if you look here where that green arrow is, there is no ophthalmic artery. And so again, if you're doing these procedures and you were to, come across this is very dangerous, because a patient with embolization material into that could end up with, into the central retinal artery, could end up blind. And this is the last one that I wanted to show, where the blue arrow there points to an example where the middle meningeal artery doesn't come off of the external carotid artery. It actually arises from the ophthalmic artery. So again, this is, lots of fine details here. And the point isn't to try and, memorize the vascular anatomy. It's just to say that there are variants. And if someone's doing these procedures, they need to be aware of those. So I just have two more images here. This just shows that the black arrow down at the bottom, that little petrous branch, the white arrowhead over to the right, that's going to be a sphenoid branch. Again, you need to be careful of these. And then those white arrows up top actually just kind of nicely show a little pinpoint bleeding, and could be areas where that hematoma is developing, or is those could be areas where there's bleeding into the hematoma. And this was a snapshot from a recent paper that just shows on the left up top, when you inject dye into the blood vessels, you can see the middle meningeal artery sprawling out, and on the right, after the glue has been injected, that it's gone. And then in the bottom, you can see the CT scans that show that hematoma is present on the left and then gone on the right. It's just a nice visual depiction. Okay, so the last thing that I wanted to mention is just that there is a nice paper that was published actually very recently, and I can provide the reference to it. But it's just that the anatomy of the dura is basically fundamental to why the hematomas develop and persist. And there are 3 layers: periosteal, meningeal, and border zone. And there are each a vascular network associated with those. So outer, transitional, and inner. And it's this inner network. That's where you have a lot of the action with respect to the subdural. The outer layer is where you're going to have that big branch of the middle meningeal artery. The middle meningeal, the meningeal layer, which happens to be in the middle, is relatively hypovascular. And then on the inside, where you have your border zone, your inner network, that's where that's where the trouble arises. So this is just a snapshot where you can see that at the top of the image, you have your skull. Over to the right, you can see PL. So that's your periosteal layer. ML, that's your meningeal layer. And BCL, that's your border cell layer. And that's where your membrane is. And you can see there's these anastomoses, or these networks. A and B, the red vessels in cross-section, those are your middle meningeal artery. So then for anyone who wants to actually look it up and who wants to learn more about it, this is an absolutely beautiful picture that was published in the paper that I mentioned. I'm happy to provide that reference, but again, it's beyond the scope of tonight, but it's really fundamental. The anatomy here is fundamental to understanding how these chronic subdurals persist. Okay, so I think with that, we should move forward and discuss the articles. Thanks for listening. And look forward to some discussion.
Okay, thank you so much, Dr. MacLean. That was a great presentation, and that was a great summary of all 3 papers. Amazing job. So is there any question before I start talking about the review paper? Okay.
I was just going to say we had a new member that I was going to ask them to introduce themselves, but I think they may have left the chat just now. But no, other than that, you can go ahead.
Okay, I can share my screen. And could you see my screen now? Yeah, okay. Let me just put the pictures below. Okay, and then could you see also my cursor as well? Okay, good. So let me just make sure I don't want to block maybe I can make it a little small. Okay, good. So yeah, so actually, first of all, before talking about this paper, I personally enjoyed reading this paper because I think it was really well written with a really simple language, and they also introduced any technical term they used during the paper. So if you didn't have a chance to read through this paper, I strongly recommend it. The title of the paper is Pathophysiology of Chronic Subdural Hematoma, Inflammation, Angiogenesis, and Implications of Pharmacotherapy. And is actually the study done by Edelman under the supervision of the Hutchinson. So actually, this is published in 2017, and it's going to basically go over the history of the pathophysiology associated to the chronic subdural hematoma, and also our current understanding of the pathophysiology and the pharmacotherapy option we have for that. Okay, so I have actually this picture. Dr. MacLean showed this picture already, but I'm just going to go over that quickly as well. So we know that we have like 3 layers for meningeal layers. We have the arachnoid layer, the PL layer, which is like right on top of the brain. And then we have also the dura layer. And we're gonna have this hematoma in the subdural layer between the arachnoid layer and dura layer. And if you look at a CT scan, as Dr. MacLean mentioned, so we're gonna see the hematoma with the hypodense color here, which is shown by the gray color. So this is actually kind of like this showing the relatively old blood. That's why we call it the chronic subdural hematoma. If you have a more acute blood, as Dr. MacLean mentioned, that will be like a more hypertensive, it will be a little bit brighter. So historically, as Dr. MacLean mentioned, the old theory was that chronic subdural hematoma is mainly caused by trauma. And the idea was that the trauma to the head can damage the bridging veins passing through the arachnoid and dura. And this venous blood can fill up the space between the dura matter and also the arachnoid matter and create these hematomas. But this idea is disputed because further studies showed that there are three main problems with this like an old description of the pathophysiology. I've just listed these reasons here. The first reason is that the symptoms associated to chronic subdural hematoma usually appears 4 to 7 weeks after any head trauma, if there's any head trauma involved. And we expect to see the symptoms of the venous bleeding to be appearing within the few days. So that's actually one of the discrepancies here between the picture we see in the chronic subdural hematoma and also the ones we expect for the venous hemorrhage. The other thing is that the pattern of the bleeding over the cerebral convexity is not consistent with what you expect from the venous hemorrhage as well. And finally, what we see in the chronic subdural hematoma is that the hematoma itself is going to gradually basically grow chronically. And for example, if, as I mentioned in the previous CT scan, so here we see sort of like the hypodense or hypotense blood here, which means that that's a chronic condition, and is not what we expect to see in the acute venous hemorrhage. So that's why they tried to modify this picture. And then in 1946, Inglis actually did a study and identified one single layer of the specialized connective tissue and the inner part of the dural layer, which I think the border cells Dr. MacLean mentioned earlier. And then this specialized connective tissue layer, they're going to do two main jobs. They are involved in the phagocytosis, and also they can also develop into the fibrocellular connective tissue, which are going to be involved in the development of the membranes we expect to see in the hematomas. So the name of this layer that I mentioned earlier would be dural border cells. We're going to refer to them later on. So after identifying this layer, Inglis concluded that if you have any hemorrhage in the subdural space, this hemorrhage can basically activate these dural border cells, and they're going to basically proceed and form the membranes we see for the hematoma. But the problem with this interpretation was that in 2013, there was another study which shows that only 21% of the patient with the acute subdural hematoma progressed to chronic subdural hematoma. It means that having only hemorrhage is not enough to see the chronic subdural hematoma. So there are only like a 21% of the people with the acute hemorrhage end up to have the chronic subdural hematoma. So then the question is that what is the main reason behind the chronic subdural hematoma? And that's created the next picture, which is actually our current understanding of the chronic subdural hematoma, which is going to basically look at this CSDH cycle. So inflammation is going to play a key role. That's going to get back to the picture that Virchow presented in mid-19th century. So based on this cycle, everything is started with the like I mean it mentioned start from the head injury trauma, but as Dr. MacLean mentioned, that might not be all relevant to head trauma. But imagine there's like a head trauma, and this head trauma is going to basically damage the dural border cells we already mentioned. So inflammation is going to be actually happen to repair those damaged dural border cell layers. And as a result of this inflammation, there are lots of mediators immigrate to the region of the problem. So there are like few mechanisms happen at the same time, which is going to cause progression of the chronic subdural hematoma. So one of these actually main mechanisms I'm going to explain in more detail would be the inflammation itself. If you have inflammation, so we have a cytokines, chemokines, they're going to call for more inflammatory responses, and that's going to intensify itself. And as a result of this inflammation, we also see we see acceleration in the formation of the membranes, which is actually the new membranous condition we expect in the hematoma. In addition to that, some of the mediators brought to the location by the inflammation are going to also initiate angiogenesis process, which is going to create microvessels within the membranes formed around the hematoma. So these vessels are usually fragile and leaky, and this leakage is going to basically bring more inflammatory cells and more blood into the hematoma, and it's going to also intensify the condition. In addition, we also have the fibrinolysis effect that I'm going to mention later on. But what I want to focus on would be the last two steps here that says that if you have these leaky blood vessels, as I mentioned, we're going to have the leakage of the blood, which is going to basically intensify inflammation. And that's going to, again, bring more and more basically mediation factors, which are going to create more inflammation and then more leakage. So that's why we see the gradual progression of this disease in time. That's why we expect to have the chronic picture here. So here I've summarized the three main mechanisms that Dr. MacLean mentioned as well. So we have three main mechanisms: inflammation, angiogenesis, and fibrinolysis. And inflammation, as I mentioned, is going to bring all basic mediators, which are involved in the angiogenesis and fibrinolysis and other stuff. So here in this picture, we see the subdural hematoma here, and it has actually kind of summarized all the factors involved in all these mechanisms. The factors shown in the green color are the main pro-inflammatory factors, such as interleukin-6, interleukin-8, which are going to basically bring more inflammation response and going to intensify the condition. Then for the red ones, we see the factors involved in the angiogenesis, which are going to be involved in the creation of the microvessels, the leaky microvessels in the membranes. And then we have the kind of like a brown squares here, which are basically the factors involved in formation of the membranes. Because, for example, if you have a hematoma and you want to expand this hematoma, we have to also develop more membranes. In addition, we also see these blue factors here, which are the factors involved in the fibrinolysis. And the idea is that basically there's also a fibrinolysis mechanism which is going to resolve any clot formed in the hematoma, and that's going to basically bring more hemorrhage and it's going to intensify the condition. So as you can see, one of the factors, for example, in the fibrinolysis would be TPA, the plasminogen activator, which is actually one of the drugs we use in the stroke as well. So that's actually naturally present in the hematoma, and that's going to accelerate the fibrinolysis process here. Here I have listed the key mediators we see in the chronic subdural hematoma listed in the paper. So as I mentioned, for example, we have the procollagens. These are the mediators we see in the inflammation response, and the procollagens are the factors involved in forming the new membranes, which are going to basically form the border of the hematoma. And then we also have, for example, TPA, fibrin, and thrombomodulin, as I mentioned earlier, which are all involved in the fibrinolysis. And then we have angiopoietin, VEGF, which are also involved in the angiogenesis process. So there are also a lot of other factors. I'm going to skip them for the sake of time. So we can now look at the treatments. As Dr. MacLean mentioned, the first line of treatment would be surgery for the symptomatic patients. If they have symptoms such as a headache and there's a chance of increased intracranial pressure, so the first line of treatment would be surgery to just basically reduce the pressure inside the cranium. However, if you don't have symptoms present in the patient, for example, if you accidentally discover this hematoma by taking the CT of the brain, in that case, drug therapy would be the favorite line of treatment. And so, as you can see here, even after surgery, because there's also a high chance of recurrence, so usually they start drug therapy after surgery to make sure that they're going to basically lower the chance of recurrence after the surgery. So here I've listed a few type of the drugs which are mentioned in the paper here. So dexamethasone is the first one listed in the paper, as we discussed in the Dr. MacLean talk. So that's really actually the steroid, as you know, and that's going to kind of work in prohibiting inflammatory response, and also as a result membrane development. So that's going to slow down the progression of the chronic subdural hematoma. Someone is going to talk a lot in more detail about this drug because he has the paper all talking about the dexamethasone. Another treatment available would be atorvastatin. We know usually we use this one for the dyslipidemia or hyperlipidemia, but another effect of the atorvastatin is actually anti-angiogenic effect or anti-inflammatory effect. So that because of these two effects, that could be also helpful in the case of the chronic subdural hematoma, because it can prevent formation of the small vessels and also is going to shut down the inflammatory response. The other actually drug used for treatment of this condition is the angiotensin converting enzyme inhibitors, ACE inhibitors we use for blood pressure control. And the idea is that these drugs are also used in the atherosclerosis conditions because they can also kind of slow down the inflammation process and vascularization within the plaques. So that's why the idea is that the same kind of the mechanism can also help reducing the effect of the chronic subdural hematoma. And finally, the last drug they mentioned is the Tranexamic Acid, which also has the antifibrinolytic drug, and that's going to basically help with the coagulopathy, and it's going to basically maybe my understanding was that it's going to stop fibrinolysis process, and as a result, we will see that these microvessels are going to be clotted, and then we're going to stop the bleeding. So in this paper, they didn't mention anything about the endovascular treatments, like such as the embolism we're going to discuss soon. But my understanding is that maybe by the time they wrote this paper, maybe that method was not that common. That's a really recent one. It's 2017. But that's a good question that we can ask Dr. MacLean. That is there any reason that they didn't mention endovascular therapy here in this paper, in this review paper? Yeah, I think that's actually the summary of the big picture presented in this review paper. If you have more questions or you want to go through the details, we can discuss any of these topics in more detail.
Mohammed, that was a really good overview.
Thank you.
You know, it's a pretty dense paper. You know, a lot of physiology here, and I think, you know, depending on you know, what level you're at, you know, some of these concepts or most or many of the concepts are going to probably be new to you, and I think one of the things to kind of try and focus on when looking at an article like this is that you know, just to try and take home the main key big points. So I'm just going to share my screen just for.
Sure. Let me stop sharing and then yeah, please go ahead.
All right. So you guys are seeing the paper here now. So are you guys able to see my pointer here now?
Yes, yeah, we can see that.
Okay, perfect. So yeah, I think this, so you did a really nice job summing up those three key pillars that I think are really the take home here.
Mm-hmm.
So in green, as you mentioned, you have that aberrant inflammatory loop. So your membrane is actually, you know, got these pro-inflammatory factors in it. And with inflammation, we know that you get leaky blood vessels and you get more immune cells. And these are all interrelated. It's probably not as important to try and focus on all the specific, you know, types of factors that are involved. Although as you progress through your training and your medical training, you become more familiar with them, and you do see them all over and over, which is helpful. But certainly, I think some of the main take-home point here would be that you have inflammation, you have problems with development of the blood vessels, leaky capillaries specifically, that can lead to ongoing hemorrhage. And then, as you mentioned, you have trouble with forming blood clots. So I think, you know, in terms of going through the paper, it's interesting to see that, you know, in terms of pharmacotherapies, atorvastatin, for example, as you mentioned, you know, medication typically thought of, you know, as you know, widely used for treating dyslipidemia, has, you know, anti-inflammatory and anti-angiogenic effects. So here, you know, you can just see that, like in summary, you know, it has an anti-inflammatory effect by reducing TNF-alpha and MCP1. These two molecules are involved in the function of the blood-brain barrier. Remember back to one of my slides earlier was talking about types of different cerebral edema, and vasogenic edema, which is thought of as being a consequence or you know, a byproduct of having a leaky blood-brain barrier. If you have inflammatory molecules like TNF-alpha and MCP1 that are making the blood-brain barrier more leaky, you can get cerebral edema. So it makes sense that if you know, use a medication that works on those, you could potentially be decreasing the leaky vessels, reconstituting the blood-brain barrier, or, in theory anyway. So that might, that might be in part how that medication is working. It says it has anti-angiogenic effects by working on vascular endothelial growth factor. These things, it's important to keep in mind, these are small studies. They're based off small numbers, and there needs to be large, large randomized trials where you're looking at the effect of these medications before we can draw really firm conclusions about their efficacy. But, the other one, it's nice to see that, you might be able to use a blood pressure medication to help, down-regulate the immune response. But a lot of these patients are elderly, and, maybe they have falls that was a precipitating factor in why they're coming in. And now, now you're talking about potentially starting them on an ACE inhibitor to help down-regulate the immune response. But what happens if they have a low resting blood pressure? Then what are you going to do? You're going to put them at higher risk of having more falls, right? So it sounds good in theory, but maybe there's more research that needs to be done there. And the last one, Transexamic Acid, there was a large trial that was published recently, actually, called CRASH-3, where they were looking at Transexamic Acid in patients with traumatic brain injury, and it was an international, worldwide randomized trial, published in the Lancet, the prestigious journal, and Transexamic Acid was found to have a marginal effect at improving outcomes in patients with traumatic brain injury. So, there might be a role here. This medication in general might help, work on improving clotting and that sort of thing, decreasing hemorrhage and recurrence. And it's generally a pretty benign medication. So you would think that if it has an effect on clotting, that it could potentially put patients at risk of stroke and things, but that's not seen. So that's reassuring. But again, I think at the end of the day, more research needs to be done on those topics.
Can I ask a question? So you mentioned that 50% of the chronic subdural hematomas are not caused by the head trauma. But in this review paper, they mentioned that actually, at least my understanding was that the whole inflammation starts because of the damage to the border cells. So my question is that, so in the cases that there is no head trauma, so what initiates the inflammation, which is going to end up to a subdural hematoma?
Yeah, no, it's a good question, and I think that's that's part of the mystery here, is what's the true reason for why these patients are presenting with chronic subdurals. I mean, it could be something as simple as elderly patients have cerebral atrophy. There's more room they're in their subdural compartment. All it takes is maybe a very minor trauma that the patient's not even aware of. And they, generate a small laceration onto, one of their fragile leaky vessels, on the cortical surface, or maybe in some cases it's degenerative vascular disease, where you just get a little bit of bleeding, and that's just enough to propagate. And as you highlighted in this article, it's an aberrant loop, right? All it takes is a small amount, and then if those the border cell layer has any sort of injury, then it draws in more inflammation, it draws in more angiogenic factors, and that just propagates. And so, it sounds as though head trauma might not be identifiable in a lot of these patients, but at the end of the day, the new thinking is that it's injury to the border cell layer. That's the fundamental take-home message from this paper. And so, there's got to be some sort of way, they've got to be injured somehow, right?
Thank you.
Okay, so I think this is my turn to present the next paper. So if Pedram could kindly help me with the sharing of the slides, that would be greatly appreciated. No worries.
1 second here.
No worries.
Start it up. Okay, let me know if you can see that.
Yes, I can see that.
Perfect.
Great. So you could go to the next slide. Perfect. So the paper here that we're looking at is titled Trial of Dexamethasone for Chronic Subdural Hematomas. So as Dr. MacLean already mentioned, hematomas are collections of blood in the intracranial subdural space. Mohammed mentioned they can be inflamed. He explained the genetics of it. What's important to recognize is that it is a very high prevalence rate in people that are elderly. The mean age of this population was 74.1 years, I believe. So that's something to keep in mind. Complications of hematomas, as have been mentioned, you could have headaches, cognitive impairments, disturbances to your gait. And again, there hasn't been a lot of studies, at least multi-center studies, that look at different cohorts of patients in different centers that indicate, the efficacy of glucocorticoids. And if you could actually go to the next slide, I think we have a chemical image of a glucocorticoid. Not that you need to know this. It's a steroid molecule, like a 14-carbon ring, 17 carbons, and then the canonical 4 rings that we observe. As if you want a Reader's Digest version of this, what they suggest is that elderly chronic subdural hematoma patients that undergo surgery were followed with this drug, and essentially they had more adverse effects and responded less well compared to the placebo. So that's, again, the summary of the paper. We're going to, of course, explain it in more detail, but that really is the main takeaway. If we could go to the next slide, please. These are just steroids. I'm not sure why I included them. I thought it was informative. So again, this is the dexamethasone is the one second right. Okay, next slide, please. So I'll explain, okay, great. So going back to the design, so this study was done in the UK, in Cambridge University. What they essentially did was they had a 2-week course of dexamethasone in different increments. So I think this was done and administered twice daily. It started, I think, with 8 milligrams, and then it sort of progressed to 6, 4, and then 2. And so this really added up to about a total of 124 milligrams of dexamethasone, and they assessed this in 2 weeks. Now, the patients that we observe over here were those with symptomatic chronic subdural hematomas. They randomized the patients almost equally. You can see over here that actually, I should mention the inclusion criteria probably first. So the inclusion criteria that they used was using cranial imaging. They identified people that had chronic subdural hematomas, and they could see this in CT. They show up as a sort of a moon-like crescentic shape in the cerebral convexities. Other sort of conditions, as I mentioned, alluded to earlier: headaches, gait disturbance, confusion, cognitive decline. Patients that they excluded were those who could not take glucocorticoids because of complications like, GI bleeding or systemic inflammation, or those that were already receiving dosages of either oral or IV glucocorticoids. And, patients that already had hematomas were, okay, yeah, so I think that's the conclusion. Okay, now the hypothesis that they had was, would taking and administering the drug improve the 6-month functional outcome by reducing 2 criteria? One is surgical intervention, and the second is recurrence rate of this. So that is the hypothesis they had initially. They thought that this and indeed would make improvements, but that is not what they observed. So anything else that I would like to note over here? Again, perhaps one of the limitations of the study, we're going to have a slide for that later on, is about 9% of the patients were lost to follow-up, which is relatively a large number. They had an intention to treat analysis, which, as I understand correctly, maybe Dr. Mark MacLean can correct me, but essentially they would exclude people that do not conform to the treatment. And again, that's what we observe over here. I don't really think there's much else that's important to be of note here. If you could go to the next slide, please. Excellent. Now, I think what's important to maybe discuss briefly is how do they measure the outcome? So there were 3 main outcomes that they observed. One is the primary outcome, which is this Rankin scale. Essentially, it's an ordinal scale, meaning it goes from 0 to 6. And what that does is that it measures the degree of disability that a patient might have, or dependence they might have on daily activities of living. This, I think, is also used in stroke patients or people with neurological deficits or disabilities. And the way that they assess this, as you can probably see, actually, if you could go to the next slide, I think it has that scale. Maybe the next slide, actually. Sorry about that. There we go. So you can see in the middle the ordinal outcomes. So the first one is you don't have any symptoms. Then, as you sort of go further along, it progresses more, right? You have slight disability, that's stage 2, moderate disability, and death as a last stage. And the way that they identified the primary outcomes was essentially a score of 0 to 3 on the scale. That was the way that they measured the primary outcome. Okay, actually, if we could go back 2 slides now. Thank you, Pedro. And the secondary outcome that they used was the Glasgow Coma Scale, which is a 15-point scale. And really all you need to keep in mind there is the higher the score, the better the neurologic status. I hope that the slides is not too small. It's a little small for my eyes, but you can see over here that this number is roughly equal for both cohorts. And then the tertiary outcome that they assessed was how many of these patients essentially underwent surgery again for the very same condition. So what else is there to note in this figure? You can see the mean age is roughly the same, 74.3, as I mentioned, alluded to earlier. The symptoms of presentation are roughly equal between both the placebo group and the one that is the experimental group. And I think these are really all the main points of interest to keep in mind. Again, is how would they be assessing the patients based on what criteria, which I think we have covered. If you could go to the next slide. Okay, next slide. Okay, so as you can observe over here, what is very important is the results indicated on the primary level that people that received dexamethasone had an 83.9% improvement on the Rankin scale, but those that were in the placebo had 90.3%. So this is a 6.4% difference. For it to be clinically significant, it has to be about 8%, but this is still something that has raised a lot of debate among physicians. And again, this is, I think, the first multi-center study that showed that. Another important point to keep in mind is that if you look at the odds ratio, which is a little bit down on the table, it's more in favor of the placebo group by 0.55. So it means that, like, compared to the group, there's a 0.55 increased likelihood of improvement for the placebo group, which again is interesting to note. Do we have actually, is the next slide the results that writes this, Pedram, or is it the previous slide? There we go. Yeah, great. Right over there. Okay. And again, what else they would be very interested in observing is, when they looked at the after surgery and administering the drug in the first 30 days, adverse events was again higher for the dexamethasone group by 10.9% compared to the control at 3.2. So that's also interesting to note. And the risk of infection was also higher. So again, my paper was a lot more straightforward, I would say, compared to Muhammad. But what is really important here to note about this study limitations, which I think is 1 or 2 slides ahead from here. Next slide. Yeah. So no, next slide. So what you observe here is, again, a lot of the patients were lost to the follow-up. And I think another very important point to keep in mind is that it was really hard to assess because most of these patients, 94% of them were already surgically, evaluated at the beginning. It's really hard to make a meaningful comparison about how well or poorly the drug worked for the management of the patients. Another important point to mention is that because of that, we do not have enough information to look at the effects of the drug on the size of the hematoma. So whether the larger or smaller it is, what exactly impact would it have? But overall, it shows that the people that were treated surgically and did not receive the drug had better outcomes, as indicated by the 3 metrics that we have discussed. And I believe that would be the overall arching ideas of this paper. Thank you.
Great summary. So this is you did a great job providing an overview of this. So this is a fundamentally very important paper. I mean, it's not terribly common to see neurosurgery randomized control trials, particularly though, well done, methodologically sound randomized control trials getting published in, New England Journal of Medicine or Lancet and those sorts of things. I don't have a whole lot to add. I might just share my screen again here 1 second. Oops. You guys seeing the paper there now?
Yeah.
Right. So, a couple of things here. So this is it's a high quality level of evidence because it's a multi-centered study. It's also, it's a randomized controlled trial. It was blinded. These are all things that improve the quality of the level of the evidence. The intention to treat analysis. This is basically just saying that if the results of the experiment are going to be based on the initial treatment assignments, that is what it's not on the treatment that the patients actually end up receiving. It's what they were assigned to begin with, and that might have implications for trial, let's say, where you're comparing non-operative management to operative management, and a patient is in the non-operative group, but then they switch over to end up needing surgery. Then, based on what, are you going to analyze them as part of the where they were assigned to begin with or where they ended up? And, but in this case, I don't know that it's as relevant. What's probably most relevant here is that, as was mentioned, the main hypothesis was that dexamethasone was compared to placebo would improve outcomes in patients with symptomatic hematomas by leading to clinical improvement, obviating the need for them to have operative management. But one thing we can see right here, basically right in the main results is that 94% underwent surgery. So what this tells us is that, their hypothesis was that, potentially patients wouldn't need surgery, but most of the patients here clearly needed surgery. So they rightfully concluded that because almost all patients underwent surgery, they can't draw any firm conclusions regarding the effect of Dex as a conservative management option. And one of the things that we, discussed a little bit earlier, I had a slide on this, I think, was that dexamethasone is really proposed to be a medical option for patients who are, maybe they don't need surgery yet, and you were hoping that you could potentially avoid the need for it. But so this doesn't really help us address that question of whether or not it's a good, primary medical option for patients who haven't had surgery, because clearly most had surgery here. So that's the first thing to take note. And then their other objective was to see whether or not it decreased recurrence rates. And interestingly enough, the recurrence rate was lower among the group of patients that got dexamethasone. But what are we balancing that against? Why not just use it for everyone? And Sam mentioned that one of the main things was that the adverse event rate was higher. And that's a really important component, because remember, the list of complications or side effects from dexamethasone is very long, right? More diabetes, higher blood sugars, more psychosis, more infections. These are not. This is not a benign drug, and it's important to consider that. So, hence the reason that there are like atorvastatin and blood pressure medications, all these other things people are trying, because if you can have an impact on the inflammation and the leaky vessels, but you want to do that with as few side effects as possible. I think you did a good job summarizing it. I think the take home from this is that this is a study that gives us information about the use of steroids in patients who have surgery. That's the take home here. So if we want to draw more firm conclusions about using this as a medical option, as a conservative measure before surgery or trying to prevent surgery, that this doesn't really give us that answer. Anyway, good job.
Yeah, I actually had a quick question. I think I remember from this was a topic that we studied for just generally ICPs, like high intracranial pressures, and one of the ways to manage them was to essentially temperature therapy, and I'm wondering if that has been considered. If you can maybe speak a little bit about if that could potentially cooling down the temperature, so allowing the coagulation to kind of take place without it's the fibrinolysis to happen. I'm wondering if that's been considered or if that just plainly doesn't work in terms of subdural hematomas.
So yeah, no, it's a good question. When you so it's important to consider that the coagulation cascade, your clotting factors, your ability to form blood clots, highly dependent on temperature. So if you have there's actually a general ideology in surgical trauma that if patients have come in and they're hypothermic when they have their trauma, they will have worse outcomes. You actually want to warm patients up. In general, you want to get them back to sort of room temperature, because the coagulation cascade doesn't work well when patients are hypothermic, for example. And the same can be said about having a metabolic acidosis and these sorts of things. Generally speaking, you want the patient to be warmed, and that's important. This is just all comers on in trauma. When you refer to traumatic brain injury, you're right. There are studies that have shown that you can cool patients, and you can try and decrease intracranial pressure by keeping patients cool. But what's generally shown is that keeping them too cool actually is associated with poor outcome, and it's actually better to try and keep them more neutral. So on the other end, the other way to think of it would be like, don't let them get too warm as well, right? Like if patients get fever and things like that, because it distorts cerebral blood flow, it distorts cerebral blood volume, autoregulation, all these things, that play into intracranial pressure, especially in traumatic brain injury. But this is the thing about a patient who has a traumatic brain injury, who you might cool, would be that they're in the intensive care unit, usually, if you're going to be doing these cooling measures. And so those could be patients with low level of consciousness, or they might be intubated, have a breathing tube in. And so, then you can play with the temperature and those sorts of things in a controlled fashion. But the majority of patients with chronic subdural hematoma are walking around in the community, and they don't have a breathing tube, and it's not in a controlled setting. So, I'm not aware of how you might be able to alter their, intracranial temperature, but generally speaking, it has cooling has a poor effect on blood clot. So that's just a general consideration.
Yeah, thank you. And another question I had was, have other agents been considered for, like, as a kind of medication or agents, like, for example, like potentially certain nutraceuticals, or even just like herbal medicines and things like that? Have those been considered? Have those been studied at all?
I'm not aware of any other really widespread medical options for chronic subdural hematoma medical management, like other pharmaceutical options that are widely adopted. This whole evolution of thinking about how to treat these is fairly recent. You look at the PubMed search results that I provided, right? It's not linear, right? It's really ramped up in the last 10 to 20 years. So that in and of itself, I think, suggests that this is drawing more attention to what was previously a field that didn't get a lot of research attention. And at least right now, there are no consensus guidelines on what are the best medical therapies to use. Torvastatin, ACE inhibitors, these things are going to get attention, and they need to undergo further study. Herbal medicines would fall into the same category. There may be potential there, but they just need to be studied in a well-controlled fashion with large sample sizes and things. At least right now, we're just not there.
Thank you.
Good question.
I actually have one more question, Dr. MacLean. So I think in this current paper, they mentioned that after the 14-day treatment, they don't do any follow-up scans, right? And I was connecting this to this thought you said at the beginning of your own presentation, where you're saying that whether it's after acute or chronic subdural hematoma evacuations, that there's no consensus among neurosurgeons as to whether they do follow-up CT scans. So my question to you is, do you think it should become a standard practice that neurosurgeons do this?
So it's a great question, and it is one that's been studied. There are, I think there was a study published in the prestigious journal Neurosurgery within the last year or two, which looked at, and I was thinking about including this in my talk, but then it was just getting too long, so I figured probably best to avoid it. But it's a good question. So I'm pretty sure that there's evidence to suggest that routinely getting a CAT scan after you evacuate a hematoma ends up actually just leading to patients getting a higher reoperation rate. So, but not necessarily for the right reasons, right? So most of the patients after you evacuate their hematoma are going to have some residual. And it sounds as though from the research that I've come across, that if you're routinely doing follow-up CAT scans, you're going to be seeing these residuals, you're going to be more likely to reoperate, and that's not going to improve outcomes. Good question.
Interesting, thank you.
Kind of following from that, there's kind of two things that bugged me a little bit about this paper. First off, they didn't discuss the mortality rate at all. Like they mentioned it in their introduction, and then towards the bottom, they just said that they threw the numbers in the chart at the bottom, and it's 8 in the dexamethasone group versus 2 in the placebo. And I guess I didn't like that they didn't mention that. And the other thing is I was kind of looking for a discussion or some information about the surgeries that did require reoperations, like what prompted them to get reoperated. Kind of thinking like, was it neurological signs and symptoms or imaging or anything like that? And yeah, none of that was really discussed in this paper, which I can understand because it is kind of outside of what they initially set out to do. It's kind of the opposite of their research question there, but yeah, just kind of, I would have liked more information on those.
Yeah, it's a good point. A lot of the time, there's a publication bias to include or discuss the results that make the paper stand out or make it look better or that sort of thing. It is important to provide a just interpretation of the results, and that's why the research undergoes peer review, and presumably whoever reviewed this paper for the New England Journal would be a world expert on the topic, or lead researcher with a lot of experience would pay attention to those sort of details. I personally didn't look into the supplementary information of the paper, which sometimes when papers get published in Lancet or the New England Journal, and they're really profound, high impact journals, there's only so much that they want to include in the primary paper because they don't want it to be too long. They want it to be succinct and to the point. So sometimes that information will be found in supplementary indices and things. But it's a good point, right? If it's if reoperation was part of their primary hypotheses, then you'd want to know why patients are getting reoperated on, for sure. Yeah.
Great discussions. Any other questions before we move on to the last paper? All right. Okay, so I'm just gonna quickly share my screen here. There we go. Okay, you guys can see that okay? Perfect, okay. All right, so yeah, so we talked about essentially the pathophysiology of chronic subdural hematomas and the use of pharmacotherapy, but what about embolization? So that is what this last paper was about, and actually it was one of the largest papers looking at 154 cases. So this is the paper by Can et al., which was published just this year, although their work was presented orally last year in October. And so they basically looked at cases, so 154 cases, and they reported the efficacy of using embolization of the middle meningeal artery to essentially treat chronic subdural hematomas. Okay, so as I think was mentioned before, the chronic subdural hematomas are essentially treated primarily. So the gold standard is to use a burr hole irrigation, or the combination of craniotomy followed by the drainage of the buildup of the fluids. And the problem with this is that this is so 30%, so up to 30%. I think Dr. MacLean was mentioning in his presentation that up to 30%. Well, the 30% is reported in this paper, but up to 30% of operative cases are associated with hematoma recurrence, and so. And as a result, to perform surgery and invasive methods, so surgical evacuation, although has been used, it has been proven to be unsuccessful for majority of symptomatic recurrent cases. And I think we talked about the treatments to reduce inflammation have also proven to be limit in the amount of success that they have. So embolization is essentially proposed, and that is what is being reported in this paper. So this paper essentially looked at 15 different centers, and they accumulated cases from January 2018 to 2019. And the inclusion criteria is essentially, they mentioned that, and this is actually one of the limitations that I'll talk about later on, but these were basically up to the preference of the surgeon of whether to use embolization or not. And generally what they found is that the people who underwent an MMA embolization were cases of showing clinical symptoms. There was an associated midline shift, and they typically found was greater than 5 millimeters, and also patients with reoccurrence after surgical evacuation. And I should say surgical evacuation, not evaluation. Some of the exclusion criteria, they basically excluded cases that there was a subdural hematoma evacuation with an MMA embolization, as well as if there was a lesion associated with the hematoma, and particularly, for example, lesions related to the vasculature, tumors, arachnoid cysts, and so on and so forth. And also, of course, if the meningeal artery was not distributing, was not involved in supplying the vasculature for the hematoma, and patients that were thrombocytopenic. As for the outcomes that they reported and they looked at, there were basically two categories. So looking at clinical patient outcomes, which looked at complications, and the NIHSS, which is the National Institutes of Health Stroke Scale, as well as the Modified Rankin Scale. And then the second category was looking at the thickness and of the hematoma and the improvement upon follow-up. And so basically, just to kind of quickly talk about the cohort that they had. So they had a total of 138 cases, but some patients had bilateral embolization. So there were a total of 154 MMA embolization cases, mean age of being about 69.8 years. And some of the patients were female, and the majority were with other genders. So in terms of the results that they reported, so this table here on the right side, table 2, kind of describes basically the location of, for example, the SDH or the SDH that was involved, and you can see the majority were involving the entire convexity, the laterality, left, right, and essentially the medial, the median thickness that they had found was the 14 millimeters, which I'll explain in the next slide as well. But what they found is that 70.8% of the patients that had the embolization done achieved at least 50% reduction in the thickness, and 31.8% achieved 100% improvement. And this is, I think we described images of this before, but this is kind of showing the improvement of a 96-year-old man who had done a left MMA embolization. So this is essentially pre-op, and this is showing B is showing 3 weeks after, and then this is 3 months after post-embolization. Okay, and so like I mentioned, the median thickness was 14 millimeters, and a majority of patients achieved at least 50% reduction. They also improved in the NIHSS score. So as you can see here in this table, this is kind of showing, from pre-op all the way to 90 days or the last follow-up. And you can see here that the thickness has reduced, the NIHSS score has improved, as well as the MRS. So that was the MRS being 31.9% of the patients. But something important to note here is the fact that although this is what they have found, only 58.7 and 73.9% of the patients had their scores reported. So that's something good to keep in mind. And this is showing essentially that their findings, so this is a table that nicely shows that the mean difference between pre-op and the 90 days, and showing that all were statistically significant. So this is a significant improvement of the patients. As for the material that was used to embolize the middle meningeal artery, so they also investigated that, and there are a bunch of different materials. However, what they found is that in the reported cases that they used, there was no statistical significance, although they may say that even the 154 samples may relatively be large, it could still be a smaller sample size. And so that may need further investigation. And something that they noted was that liquid embolics can actually deeper penetrate smaller vessels. So it might be, this might be an uncontrolled and unwanted use in certain cases. So that's something that they noted out. In terms of the functional outcomes, they also mentioned that the functional outcomes for the MMA embolization was mostly improved for the patients. And by the way, this is actually a figure on the right side, figure 3, kind of showing a visual of the MRS pre-op compared to 90 days follow-up. And they also, let me just bring up my notes here. Yeah, so they also reported that although small, 22.9% of cases demonstrated a worsening in their NIHSS score. As for the majority of the patients, though, so 90% of the patients in their series had a favorable functional outcome. And this is comparable to a study that they reported, which previously, basically, they reported an 85% of patients had a favorable functional outcome. So this kind of shows the sort of a good way to, the validity of the paper, which is comparable to previous studies. And next, just talking quickly about the complications. So although the complication is not uncommon for surgical methods of treatment, rates are generally lower with using embolization of the middle meningeal artery, as well as so that's with respect to the complications. However, I think Dr. MacLean very nicely talked about how that embolization can essentially so the material, the embolized material, can actually be used elsewhere, and they could essentially flow into different regions, especially into the ophthalmic artery through the meningeal ophthalmic connection, or via the vasonervorum, which goes to the facial nerve. And this actually, they did report that one of the patients, one of the cases, they had a facial droop. And so these kind of complications can occur. However, if proper investigation is done by the angiography, then you can essentially seek out these collaterals and the different variations in the patients and in the cases. And if you know exactly, where the vessels are located, then you can avoid certain complications that could potentially arise. And lastly, they talked about the limitations and the future direction of where embolization is going. Is that so there were a few limitations that they pointed out. One being that I mentioned earlier, the surgeon essentially the selection of these cases and who gets MMA embolization versus who doesn't was based on the preference of the surgeon, which is subjective to a degree. And in fact, the techniques that were also used were different in the different centers. So that could essentially limit some of the findings. And they also reported that there was no independent data collection party that was utilized in the study. And this could essentially introduce another level of bias. And lastly, no randomization was was performed in comparing these the cases. And in fact, in the future direction, what they talked about is we need, although there are some randomized controlled trials and non-randomized trials underway, there needs to be more investigations in terms of controlling these factors and comparing them directly. For example, looking at the embolization techniques versus surgical and conservative treatments, looking at the efficacy of primary recurrent hematomas, subdural hematomas, and also determining if there is a difference between the embolizing agents or the materials that are used, and if so, which is the best to use that would minimize complications and so on and so forth. So that was essentially the paper. It was pretty straightforward, but a very interesting finding actually, and it's kind of paints the picture of how people are thinking, researchers are thinking in investigating how to treat or chronic subdural hematomas in another way after post treatment or things like that.
Great overview, Peter. It's that was a great breakdown. There are a lot of nuances to this trial, things that it sounds really great. This new evolving therapy sounds effective for decreasing size and things like that. But there's some fine details which I think you pointed out nicely that are worth paying attention to. So I'm just going to screen share again. Are you guys able to see? You're able to see the paper? Yeah. Okay. So this is one of the biggest studies to date. The good thing is it's consecutive and it's prospective. So those are that's from a trial design perspective, that's advantageous. It's not a randomized control trial, so it's not the highest level of evidence. And the authors do call for a randomized control trial, which I think is appropriate. They were really looking at the proportion of patients requiring additional surgical treatment within 90 days. And then also they're looking at radiographic improvements. So they're looking at the CT scan and they're looking to see whether or not the hematoma gets smaller. So a couple of things to consider. So, 30% of these patients were on antiplatelets. 30% of the patients are going to have issues with blood clotting and that sort of thing at baseline. A lot of the patients who are on these medications can come off of them, but there are some patients who cannot. So one of the things that might be nice about an endovascular approach is if you have a patient who you really don't want to stop the antiplatelet therapy or the anticoagulation therapy like warfarin or rivaroxaban or whatever, if there's a medical reason for that, this is just to say that you can do this procedure and these patients can be kept on this. It's no problem. So that would be one, advantage to this form of treatment would be that you don't need to stop those patients' antiplatelets and anticoagulants. Although, it would seem kind of counterintuitive. It's like, well, if you're worried about ongoing bleeding, maybe you should be stopping them if there's no medical contraindication to doing so. In terms of the outcomes here, so I have just highlighted, 6.5% recurrence rate. And for surgery, as mentioned, the numbers fall sort of between the 10 to 20% range. So it's a reasonable, a fairly good recurrence rate. And then 70% of the patients achieved, at least a 50% reduction in volume. So what this trial does tell us is that from a radiograph perspective, from an imaging perspective, the hematomas do get smaller after you embolize them. In terms of complications, having a facial droop, like that's a severe complication, right? Like that's really, that's not good. And so I'm not familiar with like, doing a burr hole for a patient under a local anesthetic, and then them developing a facial palsy. You'd have to like injure their, primary motor cortex or something. It just, that wouldn't really occur. You have to do really a randomized control trial and look at the nuances to try and tease out differences in complication rates and such. That's not the purpose of this paper. But this facial droop does draw, attention to the fact that, here you can see dangerous collaterals were seen in 9%. So that's kind of why I showed a few of those images from neuroangio.org, just showing that, there are connections between the external carotid arterial circulation and the internal carotid arterial circulation, where you could end up potentially embolizing the facial nerve blood supply or the ophthalmic artery and visual supply. So what's the relevance of this? This study was done by presumably world experts, right? This is going to be leading edge institutions in the US where these people are highly trained endovascular surgeons who are experts. So if we're talking about adopting a therapy, we need to think about generalizability. So do you think that this, if there's a 10% collateral rate, that if this gets adopted by every endovascular, therapist out there, is that complication rate going to be the same? And, what percentage of patients, like, is a 10% collateral, going to pose a significant risk? Like, is the complication rate going to be much higher if it's adopted very broadly? It's a point worth considering. The other thing I have highlighted here is general anesthesia. This is the last one that I wanted to mention, or one of the last things I wanted to mention. Almost half of these patients had to be put under GA. That's a big deal for patients who are elderly and medically comorbid. And one really good thing about doing burr holes, for example, is a lot of the patients don't need a GA, and you can do a scalp block with local anesthetic, and patients back in the recovery room or up on the medical ward, within hours, not even, and don't require GA. So again, if those people who say that endovascular therapy is really the new evolving thing because it helps decrease the invasiveness of the procedure, well, this is suggesting that a lot of these patients are needing a general anesthetic, which is pretty invasive. So that's something to consider. The other thing, which I think Peter mentioned quite nicely, was that, if you're looking at the modified Rankin scale, that's not really the main, it's not really the best thing to be looking at in this study, because a lot of these patients are not symptomatic. They're not experiencing the focal neurological deficits it's going to take them to need surgery. These patients are, you can see here, MRS 0, 1, 2, 3. The majority of these patients those are patients with relatively minimal disability. And that's who this applies to. Patients that don't have a lot of disability, who you feel more comfortable, you have a little bit more time, they don't have an urgent need for surgery. So it's not surprising really that you don't see a whole lot of difference. Most patients are relatively good functional status, and then after the surgery, they're also pretty good functional status. I think what it tells us more so is just that a lot of them don't deteriorate, which is good. So it shows that it's a relatively safe, aside from the other implications we mentioned. And then the last thing is that they highlight the need for a randomized trial, and that's true. And then, they point out some of the limitations in the study there, which I'm not going to highlight anymore. I think you highlighted that nicely. But yeah, it's an evolving therapy, and it's new, and I think it's going to get attention, and it's not going anywhere. I think that it's here to stay, and it'll be used in select cases, and then further high level data will help us determine to what extent it'll find its way into common neurosurgical practice.
Can I ask a question? So we talk about the surgeon's preferences in doing surgery or other treatments like drug therapy or the embolization. So as a surgeon, what's your criteria to decide whether you want, if you have like a patient with the chronic subdural hematoma, whether you want to go with the surgery or you start to do embolization or drug therapy?
So generally speaking, you look to the consensus guidelines. For many aspects of neurosurgery, there are consensus guidelines. And so you would go to those. For example, if you wanted to know about whether or not to treat a patient with a traumatic brain injury with certain therapy or not, you go to the Brain Trauma Foundation guidelines published in the journal Neurosurgery, and you can quickly find that. And that's something you would study during residency, so that you develop the practice and you understand the rules and regulations, so to speak. But there are not guidelines for everything, and there's a lot of subjectivity and surgeon art, if you will, where you learn to practice based on your own experiences. And generally speaking, if you have a patient that is relatively stable, they don't have significant motor weakness or sensory deficit or decreased level of consciousness, in other words, focal neurological deficits, then you could probably trial them on a corticosteroid if you felt it was safe. But as the evidence shows tonight, I think that there are risks associated with that. So it's making people question whether you would. And then if you are trying to determine whether you're going to surgery or not, well, if they have those focal deficits and they're deteriorating, you need surgery. And if you are getting repeat imaging and their hematoma is growing and there's a lot of mass effect, you might want to intervene before they start to deteriorate, because playing catch up is never as good as getting it done before a problem arises. Right. So these endovascular therapies, they fit into, at least right now, treatment of patients who do not have focal deficits where they're deteriorating. Right. These you're talking about the more stable patients where you have more time.
Thank you so much.
Yeah.
Any other questions from any of our participants about any overarching ideas? No? Okay. So we would like to again thank all of you for showing up, and Dr. Mark MacLean for leading this great initiative. It was very informative. I learned a lot. I'm sure everyone did too. We're going to now stop the recording because we're opening up the floor with Dr. MacLean's permission about residency and any inquiries any of you might have. And he's kindly agreed to stay a few minutes over time. So we could maybe do